Now let's look at process interoperability. This is a newer concept than technical and semantic interoperability that has arisen out of the need for more trusted relationships in exchange of data and coordinating care with high-quality, low-cost providers. Examples include adoption of security standards. For example, does the physician office use the same due diligence in password creation and use as the hospital? There are many concerns here. Another example, is the same strength of encryption used at the Medicaid office as at a provider setting? Again, another issue of being able to share data effectively, efficiently, and safely and securely. Adoption of workflows is certainly an issue of process interoperability. For example, what time was the patient admitted? When the order was placed, when the patient arrived in the bed, when registration occurred, etc. Actually, this may impact how many days of care a health plan will cover. So this is a huge issue. Is placing a patient in a bed on an inpatient floor an admission, or is it an observation which is not covered by Medicare? Many Medicare participants are very concerned about this use of observational beds. Has the physician office recognized that regulations now permit release of lab results to the patient prior to physician review under the CLIA regulations? This enables patients to look at lab results and clarify whether their provider action steps to be taken. In one example, a patient was put on a gurney and was being wheeled into surgery early in the morning, despite that lab results available the day prior revealed a urinary tract infection that precluded the surgery. A costly and very inconvenient result had the findings been available for the patient to review and to contact the provider about. Adoption of best practices might also be considered a process interoperability challenge. For example, do offices encourage their patients to get regularly performed lab tests done prior to a visit instead of after a visit, which would reduce time waiting for review and actions that can be taken with respect to results? Most diabetics, for example, know they have to get their A1C tested before they see their physician, but many physicians don't send a reminder or don't encourage or even quote-unquote allow patients to do that. Are providers accessible off hours, or do patients have to go to the emergency department for non-emergent conditions? We've talked about this several times under various aspects of value-based care. Has the primary care provider been notified of the patient's admission? The primary care provider is essentially the general contractor for their patients, and primary care providers should be able to help in medication reconciliation and other aspects of coordinating care before and after a hospital admission. There are many other process interoperability examples that could improve healthcare overall, making it more efficient and effective, and which are especially important in achieving better interoperability that will support value-based care success. Policy interoperability. I equate this to ONC on this slide. It is certainly a newer concept than even process interoperability, but as I said before, may be the most important and challenging to address. Policy interoperability refers largely to enforcement of standards adoption and use, but also the ability to mandate adoption of standards. Policy certainly exists in any organization, but in any heavily regulated industry such as healthcare, it often begins with federal or state regulation. In the case of healthcare, the Office of the National Coordinator for Health IT, or ONC, who we've referenced frequently in this MOOC, is the primary source of regulation on health IT and therefore interoperability, although there are other sources as well. The list of challenges ONC recently discussed with an interviewer reflects their concerns going forward. This list does not include finding new ways to achieve interoperability. ONC has long left that to the standards development organizations and industry as a whole, but their ability to promote change can focus on areas where regulations are possible, where enforcement via existing regulations can be strengthened, or where, in the absence of regulatory inclinations, encouraging collaboration and coordination through funding, posting to its website, acknowledging in conference presentations, and other platforms. All of this really can help. So current federal interest and movement has occurred in several areas. Let's take a look at the 5 identified by ONC. Developing a standardized way of identifying patients was the first thing that came out of ONC's mouth, essentially. A huge issue. A national patient identifier has been precluded by congressional budgetary constraints due to privacy concerns in the past. This has finally been clarified under the 21st Century Cures Act in a way that enables a private organization to launch a national patient identifier. Several organizations have been working to develop such. And this is being encouraged by ONC, which has its own effort as well. The second area of concern from ONC is enforcing health IT interoperability standards across care settings and facilities. This has been recognized as an issue, of course, and this, I think, is what everybody says is their number one issue. And there are alliances, collaboratives, networks, etc., addressing the issue, but primarily at a local, regional, or state level. Federal authority has largely been corrective action rather than penalty-based. And I'll tell you, many people really do feel like the enforcement should be a more stronger penalty-based enforcement to really get people to sit up and recognize these standards. Not everybody agrees with that, though. The third concern from ONC was enforcing industry-wide interoperability measurement standards. ONC has proposed an interoperability standards measurement framework that would require health IT developers to report the percentage of end users utilizing a particular standard, the volume of transactions by standard, and the conformance and customization of standards following implementation. Now, I think ONC's proposal here to measure standards adoption seems to me to be somewhat challenging, although there is one organization measuring adoption and use of the HIPAA financial and administrative standards, which is the CAQH index. Coordinating stakeholders across the industry through collection of useful information may be the primary way ONC can help the industry at this time. There are advisories that they have been releasing that can identify existing standards for users and gaps where standards development organizations can play a role. These interoperability roadmaps and interoperability standards advisories have come to be issued annually. Finally, ending the information blocking and data sharing impediments seems destined to occur, which is the good news. ONC played a major role in bringing the issue to light and challenging the industry to overcome such practices. Now, 2 of the major EHR vendors have taken this to heart and are setting examples for others.